NAPLEX video number 6. I'm going to run out of fingers soon. So we're going to talk about stroke, ischemic stroke to be specific. I have another video on stroke if you want to look that one up. It's more detailed, but here's stroke again. Definition: acute onset of focal neurological deficits that involves permanent infarction of the CNS. Versus a TIA, or trans-ischemic attack, which is similar to ischemic stroke, but caused by focal brain, spinal cord, or retinal ischemia without an acute infarct. So there's no blood supply loss. It was just like, oh, blood supply lost, and then it came back. Whereas an infarct it's been included, and you can't get blood there anymore. Pathophysiology: atherosclerosis of carotid artery leads to the formation of plaques. If the plaque ruptures, collagen is exposed. So I'm a plaque, I ruptured, collagen is exposed, resulting in platelet aggregation and the thrombus formation. Thrombus. The clot may break off and cause cranial vessel occlusion, resulting in ischemia. So the clot will break off and go to the brain. Presentation: unilateral weakness, visual impairment, and inability to speak. How scary is that? That's terrifying. Diagnosis: CT or MRI. Risk factors: hypertension, hyperlipidemia, diabetes, smoking, and AFib, because that's AFib's job. Prevention: keep all those risk factors under control. So A1C less than 7%, high blood pressure, take your meds, less than 130/80, LDL less than 100, AFib, take your warfarin. So acute treatment overview: aspirin and TPA. Let's just dive into TPA. It's a fibrolytic agent that binds directly to fibrin, causing plasminogen to convert to plasmin, and plasmin then dissolves the clot. So dosing: it's 0.9 mg per kg, 10% bolus, and then the remainder, 90%, if used over 1 hour. So max is 90 milligrams. So if you have a 100-kilo patient, you'd give them 9 milligrams bolus and 81 milligrams infusion over an hour. You want to administer within 3 hours of symptoms if onset is unknown. The benefits seen up to 4.5 hours. Exclusion: if you're 80 plus, you're on PO oral anticoagulants, your stroke score is greater than 25, history of diabetes and stroke. Side effects: bleeding. It's also contraindicated because you can bleed. It's contraindicated if your platelets are less than 100K, you have a history of ICH or intracranial hemorrhage, elevated APTT, whatever, or recent head trauma, stroke in 3 months. So TPA, it's good for you. Also, you need to give aspirin. So 325 milligrams. Give 24 hours after TPA if TPA is given. So now let's talk about blood pressure. You want to, if it's elevated, reduce it by 15% in 24 hours. So 15%. If the patient has not received TPA and they've had a stroke, you want the blood pressure less than 220/120. If they have had TPA, it's less than 185/110. Meds that you can use to decrease that blood pressure by 15% in 24 hours is labetalol, nicardipine, and nitroprusside. No one uses nitroprusside. So now let's go to secondary prevention. Aspirin. It irreversibly inhibits platelet COX-2, leading to reduction in platelet aggregation. 50 to 325 milligrams a day. Side effect: GI ulcers. Yo, bleeding. Clopidogrel irreversibly inhibits ADP-induced platelet aggregation. There's an increased risk of neutropenia and thrombotic thrombocytopenia purpura and hemorrhage compared to aspirin. And then we've got dipyridamole plus aspirin, or Agrinox is the brand name. And it's aspirin plus a PDE, resulting in accumulation of so it inhibits phosphodiesterase, resulting in accumulation of adenosine and AMP and platelet aggregation inhibition. Patients tend to have headaches with this, so they don't use it. Anticoagulation: for AFib, you need to be anticoagulated. Warfarin or Xarelto or Eliquis, your choice. more like your insurance's choice, but meh. Hypertension meds, so this is still secondary prevention. So we've got our antiplatelets, so either aspirin, clopidogrel, or Agrinox, or if you have AFib, anticoagulation. And then hypertension meds. There has been some studies that show that thiazides plus or minus an ACE inhibitor are best for stroke prevention. And then a statin. And that's all for stroke. Like I said, I made a video on stroke before. If you want to take a look at that one, it's more detailed. But catch you on the flip side for video 7.